I think the recognition of COVID-related strokes has the potential to unlock a key aspect of stroke that we don't really understand. And that is why and when are strokes striking individuals.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 120 of the Strokecast. Today, we're going to talk about how COVID-19 causes stroke. We're actually going to get into the research and the biology of what is happening there. I talked about this a little bit in the last episode where I spoke with Dr. Dilip Yavagal about stem cells and mechanical thrombectomy. But this week, we're going to go deeper specifically into the COVID stroke link with Dr. Jason Hinman. Dr. Hinman is the assistant professor of neurology at the David Geffen School of Medicine, and also he's the interim director of the stroke program at the West Los Angeles VA Medical Center. So he's a pretty busy guy. So I'm very appreciative of him taking the time to talk to us and to actually having the time to do his research. His latest research at UCLA involves creating models of the brain's circulatory system and then using that 3D model to actually figure out how COVID-19 causes stroke. We actually talked about a few things before the recording got started here, so I think they may help with some of our discussion. First of all, a COVID-19 infection increases the risk of stroke by 1.8%. Now, that might seem like a small number, but it really adds up because that turns out to be about 1,500 more strokes a week or 78,000 a year. Now, keep in mind, the total number of strokes in any given year in the U.S. is about 800,000. So this represents almost a 10% increase in stroke at a time when hospitals are already bursting at the seams and treating people in hallways and ambulance bays. Second, COVID-19 induced strokes also have a higher mortality rate and more significant disabilities than other strokes. That seems to be due to the damage that the virus has already done to the body by the time the stroke actually hits. Third, while the initial research showed that COVID-19 mainly causes LVO strokes, or large vessel occlusion strokes, which is basically ischemic strokes or clot-based strokes in the larger arteries within the brain, those can actually be treated with mechanical thrombectomy and TPA, as we learned from Dilip in the last episode. But now what we're seeing is that COVID-19 is also causing other strokes that occur deeper in the brain, in the narrower arteries. It's causing hemorrhagic strokes or bleeding strokes, and it also appears to be causing aneurysms to grow. And when an aneurysm gets too big, it bursts, and there you have another hemorrhagic stroke. Dr. Hinman also told me about one of the cases that he saw where, he had one person who had the virus, and they were treated at home because theirs wasn't too severe. Now, his caregiver seemed fine, other people at his home seemed fine, but then his caregiver turned up at the hospital with a stroke. Once there, she was diagnosed with COVID-19. Well, she did not display any of the traditional symptoms, the loss of taste, the trouble breathing, the loss of the sense of smell, and other things. It didn't matter because COVID-19 was already ravaging her system and ultimately causing that stroke. And they're actually seeing a number of people at the hospital diagnosing them with COVID-19 once they show up with stroke and then test them. So these COVID infections that people don't even realize they have are causing more and more strokes. The fact is that this virus can be extremely stealthy. You can be infected and continue spreading it without even knowing it. We've heard again and again that you can be infected and have no symptoms for up to 14 days. And that's one of the reasons why it's so dangerous. I mean, when you look at the things like the SARS virus or the flu viruses that have been out there, which of course are very different because this is not like the flu. But viruses and diseases that are more severe faster, that show symptoms and really just sort of knock you out very quickly, tend to be less dangerous to the society because we're able to isolate people. We're able to find out who has it and get them treated faster. With COVID-19, people are out there spreading it without having any idea that they're sick. I mean, really, we all have to be operating under the assumption that, I might have a COVID-19 infection and there is no way for me to know. So there is that. And that's one of those things why it's more important than ever to be able to recognize the signs of stroke. Be fast. That, of course, stands for balance, eyes, face, arms, speech, and time to call an ambulance. Sudden loss or change in balance, sudden change in eyesight, facial drooping, loss of full arm control, slurred speech or language problems. If you see any of that, it's time to call an ambulance for yourself or for somebody else who you see those signs in. Be fast. Balance, eyes, face, arm, speech, and time. More and more people are subjected to more and more potential strokes, so let's make sure that everybody knows to be fast. With that in mind, let's take a deeper look at COVID-19 and stroke with Dr. Jason Hinman.
As the literature has matured, we now understand there's a variety of stroke subtypes that are associated with COVID, including brain hemorrhages, multiple tiny strokes scattered throughout the brain, and even in some cases, aneurysmal formation of the brain blood vessels. And so I think we currently lack a clear understanding of why we're seeing such wide variation. One concept that drives at this is that COVID patients tend to be very sick, even if they're not in the ICU. And this may be driving all kinds of unusual pathology that can ultimately lead to stroke and brain pathology.
So, and that's really important for a lot of reasons, but among them is that we have seen a lot of success with clinically treating large vessel occlusion strokes through things like mechanical thrombectomy and TPA. But once we get into some of these different causes of stroke, some of the more hemorrhagic stuff, those treatments are obviously either not appropriate or not as effective in a lot of those cases.
That's definitely true. I think, it remains really important, though, to, recognize stroke warning signs. And while those can be somewhat varied in these other types of stroke, I think in general, the classic stroke warning signs are preserved in most cases.
So we're still should be looking, especially anybody who's been through COVID or had COVID in your household should definitely be high on alert for the be fast signs then.
Yeah, of course. And it would be important to remind your audience that despite media reports of overwhelmed hospitals, it's critical to seek the appropriate and urgent medical care when having symptoms of a stroke. While COVID has definitely impacted the care of patients with other diagnoses like stroke and heart attack, in my experience, stroke teams have been very adaptive. And if necessary, we can treat patients in ambulances, in hallways. We can't do that if you're not here.
You've mentioned we're seeing higher mortality from these COVID-connected strokes. Are there other ways in which these strokes are differing from what we typically see in stroke patients?
Right. I think there's two aspects to that. One is that definitely because patients are often concurrently ill with COVID-19 and respiratory complications, I think that's driving a higher mortality, unfortunately, in many patients. The best reporting on post-stroke disability, however, comes from a fairly deep case series in Italy, in which they clearly described that COVID-19 related strokes resulted in worse functional outcomes. Now, whether that's just an early response because patients remain compromised from a respiratory status, or whether that's reflects some underlying change or worse pathology is unclear. And then I think another main difference is that we have strokes affecting younger people without traditional risk factors or even with traditional risk factors, but at an age where we wouldn't necessarily expect them to present with a stroke complication. And to me, the most troubling is similar to the case I described earlier, in which patients don't have a primary respiratory complaint or symptomatology, but yet are coming in with significant strokes, large vessel, and other types. So to me, that's the most striking difference.
And that's one of those, also just one of those real insidious things about this disease is often the delay in symptoms manifesting while it's doing the damage. I mean, it's not like the stroke that comes from somebody who is previously not showing respiratory conditions is the first instance of the virus actually damaging the person. The stroke is the result of the damage that this virus has been doing to somebody's body even before they had any idea they were infected.
That's right. And I think, there were hints of this in the first SARS epidemic in the early 2000s. But as you know, that didn't spread as widely. And so we didn't get a full description of the symptomatology from that, because it was associated with a high mortality. And frankly, the pandemic was controlled much more tightly. And so now with millions of cases, you get a chance to see the full diversity of the viral disease. One thing people forget when they relate this to influenza or other diseases is that this is an entirely new coronavirus infecting humans. We've never seen this. We have no experience with it prior to, early December of last year.
When you make that comparison to the previous SARS epidemic, which ironically ended up being safer for the general population because it struck people so much faster. Did we start to see increase in strokes from survivors of that epidemic as well?
Again, the numbers were quite limited. So there were only about 8,000 cases, and so we didn't get a full spectrum of the disease. There was a high mortality. About 10% of those patients passed away, and I think because it didn't spread globally, we didn't have a chance to sort of get a full look at the variant pathology. There were some limited case reports of stroke associated with that pandemic, that epidemic, but we didn't see, it wasn't a common feature of the disease.
Interesting. I think, and one of the other things too is that since it was more geographically limited, it was harder to tease out some of the broader trends of the virus itself versus what's impacted by local conditions and populations.
Indeed, at least in the U.S., we're seeing racial and ethnic differences, and while those certainly could relate to socioeconomic factors, they could also relate to biology. And so there may be underlying biology that could portend different outcomes in different patients. And we never really got a chance to understand that in the first SARS coronavirus outbreak.
As we're sort of looking into this in deeper perspectives, then your research actually has sort of been looking into just sort of why this is happening, why we're seeing this increase in stroke from COVID. And it's been some pretty fascinating stuff. I mean, how did you conduct this research itself?
Oh, well, thanks, Bill. I mean, so it's a somewhat interesting story. I mean, just as the pandemic was breaking, my colleagues and I had received some new funding from NIH to study a major stroke risk factor called intracranial atherosclerosis, or narrowing of the intracranial blood vessels. And worldwide, this is a common cause of stroke, and we don't understand as much about it as we need to. So for this project, we had created this really cool tool where we can take imaging studies from patients, like many of your audience may have undergone, CT angiograms or MR angiograms, and use that actual patient-derived data to make 3D printed models of the human brain blood vessels from them. We make a silicone model out of that, and we can line the internal surface of the 3D models with human endothelial cells from the brain, essentially recreating the lining of the blood vessels with the anatomy and hopefully with the biology that most patients are experiencing. This model, to us, seemed pretty ideal to study a uniquely human disease like COVID-19. And so after a short period of deliberation, we just decided to jump in and see if we could model the interaction of the virus with the brain endothelia, recognizing that this was probably a driver of the increased risk of stroke that was being reported in the clinical literature. So it was really just fortunate that we were poised to do the work at the right time, and it seemed like to us very logical to flip this technology into a study of the problem of the day.
And that's really fascinating what we're able to do with that technology and that imaging now. I mean, when we're talking about taking your MRI and your CT scan and then turning that into a model of the unique pattern of blood vessels. And when we say intracranial, we're talking about the blood vessels that are running sort of throughout the brain and the skull and all of that stuff that's in there. I mean, that is really sort of a next level selfie to be able to produce of a person.
Never thought of it quite that way, but yeah, it's a 3D selfie inside the brain, and it is really remarkable. And I think pretty soon we're going to be able to do that at an even deeper level, in which we're using not only the individual patient's anatomy, but also their cells. So we can, with advances in stem cell technology, we can change those cells into take cells from a patient and turn them into endothelial cells, and then use that to line the model, making it even more of a precision system. And we've used it in a few cases here at UCLA for advanced surgical planning for treatment of aneurysms, where we 3D print the aneurysm, and we can use stents and other devices that are used to treat those to really design the appropriate therapy for that particular patient. It's not something we can do necessarily in the acute setting when there's an urgent need for treatment, but when there's time to plan and choose appropriately what the right strategy is, this can be a very helpful technique.
And also sort of giving the neurointerventionist, the surgeon, the opportunity to practice even before actually going into the actual patient.
That's correct.
As you then began studying these endothelial cells, which my understanding is that these are just the standard cells that just line the inside of all of our arteries and blood vessels. I mean, what did this reveal about sort of the mechanism behind these COVID-19 induced strokes?
Well, I'll start by saying it's still not completely understood. And working with this type of virus is not something that we had any real experience with. So we're still warming up to the really critical experiments that I think will drive to a mechanism.
Well, as you pointed out, this whole thing just popped up in the last 13 months. It's amazing we've come this far this fast.
Right, indeed. And I think it's our lab's belief that it is, in fact, the interaction of the virus itself, particularly through its surface spike protein. Of course, the now famous spike protein that the vaccines have been used to target, that this spike protein then interacts with the blood vessel using a protein called ACE2, a receptor for the virus. And this is similar to SARS-CoV-1 and the outbreak from the early 2000s. And because we had that and we understood some of the biology, a lot of tools already existed to start to understand it, and that's definitely sped up the research. But this interaction of the spike protein with the blood vessel human ACE2 molecule alone is enough to trigger clot formation, and that could cause a stroke. And invasion of the virus into the brain blood vessel cells is also likely. It's been reported. And this probably accelerates the phenomenon I mentioned of clot formation. We're working right now to understand that, see if we can inhibit it. In some instances of severe COVID, inflammation is dramatically elevated throughout the body. This could be causing clots to form and travel up into the brain, like in other conditions such as atrial fibrillation. But there's still a lot of work to do on identifying the underlying mechanisms. And it's challenging work. Not a virologist by training. Working with this virus requires a lot of safety precautions. And then, we're trying to do this work amidst the restrictions that everyone's dealing with, and in Los Angeles right now, it's particularly restrictive.
Right. So these protein spikes on the virus that it appears to be what's irritating these endothelial cells and then is making them more likely to start forming clots?
Yeah, we haven't shown the clot formation definitively, but what we see is that there's increases in inflammatory proteins after that interaction of the spike protein with the blood vessel. There are interactions that drive up inflammatory proteins that likely feed into thrombotic cascades and result in clot formation.
So, and in the inflammatory proteins, then, and those inflammatory responses, that is basically sort of a swelling of the material on the blood vessels. Is that a fair description of what that means?
Yeah, I think it's more of a signal that that there's an injury, and that in the blood vessel, one of the responses of that signal is for clot formation, to make sure there's no leakage of blood out of the blood vessel.
And that makes sense as a response at the first level, but as we see those clots, then that gets out of control, and that's how we lead to strokes. And as you mentioned, if this is also then resulting in clot formation elsewhere in the body as well, like you say, you mentioned atrial fibrillation, which can lead to clots, which can then throw clots further into the brain when the heart doesn't clear itself enough, or if a patient already has a pre-existing PFO, a hole between the right and left side of the heart that allows clots to pass through, allows blood to pass through without going to the lungs first, that increases the clotting risk. So we're seeing, it almost sounds like we're seeing already irritated then blood vessels throughout the body and the brain, and then the potential to generate more clots can then, of course, throw that elsewhere too. And of course, this is not where we're at with the research yet, but it seems like, again, from my limited perspective here, that is some of just all the stuff that cascades to causing these problems.
Yeah, I think that's a great synopsis. And as I mentioned, I think we don't totally understand it yet. Our group is focused on the idea that the virus directly interacts with the endothelium, and what are the factors that drive that. And so that's where our focus has been. I think the other things that you talked about can potentially be treated. And in fact, many COVID-19 patients are treated with blood thinners to try to prevent those widespread systemic blood clots. But if you have the virus directly invading the brain blood vessels, anticoagulation and blood thinners won't really address that. We have to sort of really understand that mechanism.
Are you seeing any indications that the virus is able to pass through the blood-brain barrier, or is it still just too big of a virus?
There are definitely some reports of that, so-called encephalitis, or brain infection from the virus itself, meaning that it's gotten through into the brain. I think that it's a minority of cases. It's not a common phenomenon, and it has been difficult to demonstrate the virus within the brain tissue. Definitely some reports, including one in December of last year, showing that there is virus in the brain blood vessels, but not a lot of demonstration of the encephalitis that one might see with, say, herpes or other types of viruses that clearly have a tropism for getting into the brain.
So sort of small favors right there.
Yes. Again, I think it's as it was described as a hit and run virus. I think it doesn't like to stick around. It likes to do its damage and then move on.
So somebody who's then been through COVID and has gotten into this hit and run, I mean, obviously, if our car's not totaled, we want to take it in for repair and rebuild and whatnot. So somebody who's been through COVID is now breathing almost as well as they used to, and has most of their heart function back, and is sort of returning to regular life, whatever that means, in after their COVID infection. What can they do to either reverse some of this damage to the endothelial, or just sort of reduce their risk of a COVID-induced stroke a month, 2 months, 6 months down the road from their COVID infection?
Yeah, I mean, I think that's another great question. It's somewhat unclear. I think the same principles of overall health are there. Get back to doing some regular physical activity as it can be tolerated. Making sure to get enough rest, and then just closely monitoring for any changes in symptoms or brain function that might be a little bit more insidious and might suggest that you need to see a neurologist or another provider for evaluation.
So the basics are do all the stuff we know we should be doing and that we've been supposed to be doing for the last 30 years to just try and generally stay healthy.
I don't think there's a secret sauce, Bill.
Oh, that's too bad. I'd go for the extra spicy. So, I mean, and obviously that's not a guarantee. Just like we know everything with stroke, you can do everything right and still experience stroke. You just absolutely can reduce your chances. And if you're healthy in general, when you do experience a stroke, your recovery tends to go more quickly, tends to have fewer complications, and you're able to get into your therapy as quickly as possible and get more value out of that.
Yeah, and I think the keys to recovery are pretty straightforward. You need the right care. You need a good doctor, a good neurologist. You need a therapist who really cares about you and your recovery. And importantly, you need a plan. So you need to set interim goals. You need to practice and meet those goals one at a time. And then, to me, I see patients who stay motivated is much more likely to have a recovery.
Yeah, very, very, very much so. It's, that attitude can make a big difference. And, what I tell people is, when we talk about attitude and mindset being so important to recovery, it's not the magic of the positive mental attitude that does it. The right attitude is a necessary condition of recovery, but not sufficient. So the right attitude puts you in a position where you can potentially recover. But if you don't have the right attitude, you're simply not going to recover at all.
Yeah, I think that's definitely been my experience.
So, like I said, you were able, when we started this project, you were able to sort of repurpose the initial research and experimentation you've been doing with mapping these vessels for other purposes. I mean, what initially drew you to even doing that research or coming up with this model of 3D printing the arterial network in the brain?
I think the thing about our work on stroke is what has always troubled me as a physician is the randomness of stroke. Many patients are at risk, but a good fraction are otherwise healthy and yet struck down by this really challenging disease that in many cases doesn't kill, but rather disables. And I think COVID really exposes and amplifies that fact. And quite honestly, it's particularly frustrating. And so knowing that we had some good tools and a great team and the relevant expertise, we just decided to jump in and move our modeling system over. I think, my team was really outstanding. I think we pieced these experiments together over Zoom with ideas coming from all members of the lab, including students as well as colleagues. It was a real team effort.
Awesome. So let's step it back though a little bit in time. Then, where did the sort of idea about producing these tools to begin with come from?
Well, one of the things that I'm interested in is understanding individualized risk for stroke and what what factors portend that increased risk. And so we had developed some platforms to recreate the smaller blood vessels in the brain, the so-called microcirculation. And it was through that series of experiments that a colleague had introduced me to a neurosurgeon from Japan who had developed Dr. Naoki Kaneko, my close colleague here at UCLA. And Naoki had developed this system where he could take the segments of the brain blood vessels and create plastic and silicone models from them. And we had already made advances in lining the interior surface of the tiny models we had made with endothelial cells. And so we had met in Los Angeles at one of the stroke conferences a few years ago. And Nyoki and I decided to work together, and he moved over to Los Angeles, and we put our collective minds together to create this model. And we think it can be really useful. We're currently using that type of thing to see if we can identify why aneurysms grow and the biology underlying growing aneurysms. And we're hopeful that that'll translate to a medical therapy for aneurysm treatment. And then after we had worked on that for a little bit, we thought that this narrowing of the blood vessels, which is an area of focus for our stroke center here at UCLA, might also be amenable to this type of modeling. And because it's a major risk for ischemic stroke, we decided to see if we could model that. So we have this larger project where we create precision models of intracranial atherosclerosis and then use that to understand how clots can form in and around those narrowed regions.
Interesting. It's fascinating how these things happen and these connections happen. I mean, one of the obvious challenges with COVID-19 is the shutdown of all of these in-person conferences. And I've been involved in a number of virtual conferences and running virtual events and things like that. And yeah, they're great. And there's a ton of value that's happening there as folks adapt and just learn how to do an entire conference online. But it does make it harder for those connections to happen. Like when you meet your colleague from Japan at a stroke conference, which can then ultimately lead to this kind of research. It's got to be tough just making those connections in those informal networks that then turn into much more formal stuff and formal research projects.
Yeah, the online platforms are really good for maintaining connections. I think it's a little more challenging without the interpersonal interaction to make new connections and to have a chat over coffee or a cocktail and discuss life or a new idea that then begets another new idea. And so I think that we're going to see a little bit of restriction in innovation because of that. And some of the stuff that happens at the meetings is just networking and people showing off their results. But a key integral component of scientific meetings is that those new connections that form and the new ideas that come from those. So I'm eager to get back. They keep getting postponed, but I think we'll get there by the middle to end of 2021.
I certainly hope so. I am itching to get back on planes and talking about stuff with groups of people when it is safe to do so.
Me too.
So what drove you to pursue this career in neurology and stroke research to begin with?
Well, without any bias, the brain is clearly the most fascinating organ. It carries a record. It carries a record of everywhere you've been. And in examining the brain, you not only learn about its folds and its connections, but also the person, their story, their passions. And in treating the brain, you then get a chance to heal this critical organ. And to me, stroke is really one of the more gratifying diseases to treat as a neurologist, because in rare cases, you get, when you can get to patients early on, you can occasionally completely reverse their deficits. And the degree to which that's rewarding is hard to put into words. And then during recovery, patients always show some form of improvement. It might be limited, it might not be as much as they want, but they always show some form of improvement as compared to when you first met them in the emergency room. And helping them get through that is really an amazing experience.
That's great. And there is so much more to learn in this space too. And I can absolutely recognize your bias. The brain is certainly the most interesting of the organs, just like the shoulder is the absolute worst designed joint in the human body.
Agreed.
So as you're doing this, it looks like there's a lot of as you're developing this research and this study platform, and really, what it sounds like here is what we've really done is we're taking a platform that you've developed for these other purposes, for researching aneurysm growth and these other things, and repurpose that for the COVID research. But really, all of this, and even the COVID research, is helping to further refine that platform with what you're talking about with stem cells earlier. How do you see this research into post-COVID-19 stroke benefiting other areas of research and treatment, whether that's in stroke and stroke recovery or other brain conditions?
This is really the most fascinating part for me. I think the recognition of COVID-related strokes has the potential to unlock a key aspect of stroke that we don't really understand. And that is why and when are strokes striking individuals. This concept of an individual's particular susceptibility to stroke is part of a broader movement of precision medicine that's ongoing in multiple fields right now. But I think it's completely achievable that a proper investigation of the relationship of COVID-19 and stroke can lead us to new and completely different stroke therapeutics. And I'm hopeful that we can start to get to that in the near future.
And as this platform gets further refined and developed, and just as we see with all sorts of technology, as time goes on, it becomes easier and cheaper to do. It almost sounds like in another 25 years or so, we could almost see just getting a 3D model, computer model of your brain done could just be sort of a general part of your physical every 5 years or so.
I definitely could conceive of that, and I think the advances both at the imaging level are moving forward every day, and so we're getting more and more detailed imaging analysis of patients' brains, and more and more longitudinal data on how the brain is changing over time. And so I think if we can combine those two things together, I think we can really make a dent in the diseases that affect brain health.
That's great. And right now, after this conversation, I kind of want a 3D model of my brain's arteries done and then printed and then sort of sitting on my desk next to me. I think that'd be kind of cool. I'm not sure I'm ready to spend the tens of thousands of dollars to do that today, but that'd be kind of cool.
I'll it may not be your brain, Bill, but I'll send you I'll send you a 3D model.
Awesome. So what do you sort of most want folks to know about the brain or brain health?
I think an important thing for people to keep in mind is, the old thinking about the brain as quite fixed, and the idea that brain injury is somewhat irreparable is a rather outdated model. And I think actually the brain is quite malleable. Recovery is possible, but it requires, a certain kind of dedication and kindness to your brain. And that means, recognizing the value of sleep, healthy eating, hydration, exercise, again, that secret sauce that we talked about earlier. And I think if you do some of those things and you really care about your brain, however your body responds, your brain will respond positively to those things. And if you do that, it'll reward you with better function.
Is there anything else you want us to know about COVID and stroke?
Well, be safe, get the vaccine. I think that, the CDC continues to recommend that or highlight that patients who have a history of cerebrovascular disease, including stroke, have a higher risk of severe COVID-19 if they get infected. And I think that doing everything we can to prevent the spread and individualized infection is really critical. So mask up, get a vaccine, and try to stay out of the hospital.
If folks want to know more about you and what you're up to, where should they go?
The best place to go for up-to-date info on the lab and its progress is via our Twitter page. That's at Hinman Lab UCLA. And I post there fairly regularly on our scientific updates and things that are in the literature that I think are critical.
Jason, thank you so much for your time today. This has been absolutely fantastic, and I have learned a bunch of stuff, which is always something I enjoy doing. And hopefully I can doing my best to stay safe and encouraging everybody else out there to stay safe as well.
Great, Bill. Thanks again for having me, and just direct your audience maybe to consider donating to the American Heart Association. That's really been leading the way in supporting COVID-19 related stroke research.
Absolutely. And we'll have those links all available in the show notes to do that.
Thanks, Bill.
We're going to see damage and death from COVID-19 infections for years to come. And it's not just from new infections. Infections people recovered from in 2020 will be causing stroke, heart disease, myocarditis, and other problems in 2021 and 2025 and 2030 and on. Like stroke, the scars from a battle with COVID will live on, not only in our psyches, but also in our blood vessels, our hearts, our kidneys, and more. This is not just the flu. It's not something you want to catch to get it over with. Plus, that doesn't even work. As Dr. Hinman points out, the SARS epidemic back in 2002 to 2004 ended up with about 8,000 cases and about 800 fatalities from that. So, just think about that. 8,000 cases, 800 fatalities. As compared to COVID-19, where we've seen 23.2 million cases and nearly 400,000 deaths in the United States alone. In the past week, there have been nearly 20,000 new cases here in just Washington state alone. The scale of what we're seeing here compared to the SARS epidemic, it's just mind-boggling, and it's getting worse. And yet it seems we took SARS a lot more seriously at the time. We saw the tremendous move to mask up across Asia. We saw temperature sensors being installed at airports around Asia and around the world to help contain this. And yet in reality, SARS is just a small rounding error relative to COVID-19. So stay safe, avoid large gatherings, and mask up. And that brings us to our hack of the week. One way I found to release your toned and spastic fingers from a fist on your affected side is to pry them open with your other hand. Of course, we all do that from time to time, those of us who are living with hemiparesis. This can work, but it does require some brute force. One thing they taught us back in driver's ed when we were learning to drive is that when you feel your car start to skid, you should steer into the skid to get control back. You can kind of do the same thing with your hand. For your fingers, try leaning into the tone and spasticity. Instead of trying to just pry them open, first bend your wrist down so that your hand goes and fingers go in the direction of your forearm, your inner forearm. Because when you do that, that will typically release your fingers, and then you can open them the rest of the way. Now, the reason this works is because the muscles that open your fingers, your extensors, actually run across the top of your wrist. When you bend your wrist down, that actually causes some tension in them that causes them to pull back on your fingers, which opens up your fist because really the extensors are not long enough to stay relaxed when you make a tight fist with a bent wrist. I find that when I do this, when I actually bend my wrist down like that, I can get enough release in my fingers that I can often make them move on their own. Of course, that movement is really only within the past year or so, though. So again, the message there is recovery continues years after stroke. So go ahead and give it a try. Try bending your wrist down to release your fingers, and let me know how that works out for you. So that's it for this week. Be sure to check out the Strokecast gift guide at strokecast.com/gift guide for stroke-related books, gadgets, and more. You can follow Dr. Hinman and his research on Twitter at Hinman Lab UCLA. Be sure to visit the show notes at strokecast.com/Jason for more links and details. Consider donating to the American Heart Association to support more research into the causes, prevention, and treatment of stroke, and to fund more research like that that Dr. Jason Hinman is doing. Be sure to share this episode with someone you know by giving them the link, strokecast.com/Jason. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.